Good afternoon, or good morning, or good evening, as the case may be. My name is Chitra Lede. I'm the president and founder of Actu-Real Inc., a company that provides services to support clinical development of new drugs and post-launch activities focused on value-based healthcare. First of all, I would like to thank all of you for joining us for this webinar today. As we all know, value-based healthcare is of interest. There's been a lot of growing interest in it recently, and hence you've chosen this topic. We are going to talk about its merits and also the difficulties of demonstrating them using a landmark study in the field of psychiatric care research. For this webinar, I'm excited to be joined by an excellent panel. So I have with me Joan Barrett, Kristen Chow, and Pierre Etienne. Joan is a senior health actuary. She's a consulting actuary with Actu Health Partners. Kristen is a consultant health economics outcomes research at Actu-Real. He has a PhD in health economics and is also affiliated with the Harvard Medical School. Pierre Etienne is the co-founder of Actu-Real and the chief medical officer. He spent most of his career in pharma R&D, but he's also a psychiatrist, and for about a decade recently, from 2010 to 2020, he returned to hospital practice and research before joining me to co-found Actu-Real. So the plan today is that for the first 10 minutes or so, we will give an overview of value-based healthcare. We should explore its definition, benefits, and then we shall move to one particular example from the field of psychiatry to illustrate how the cost effectiveness of a comprehensive integrated care for first episode psychosis can be assessed. We'll make some observations about the outcomes from this example, the lessons learned, and also their applicability to other scenarios. Subsequently, we'll open up for discussion and for questions. So all of you who have joined us for this webinar, please feel free to submit your questions through the Zoom chat at any point during the webinar. We'll take all of those at the end after the panel discussion is over. So with that said, I would like to request Joan to take over.
Thanks, Chitra. So as she mentioned, we're going to, in this webinar, define value-based care, explore some of the benefits, and give an example. First, a little background. In the United States, most healthcare spend is based on a fee-for-service reimbursement method. As that name implies, providers get paid based on the specific services that they perform. Although most providers work in good faith, there's no financial incentives for them to reduce cost, to improve quality, or enhance the patient's experience. Under a value-based delivery system, providers are explicitly financially incented to do those things: lower cost, provide quality, and enhance the experience. In some cases, the incentive comes in the form of a monthly capitation amount used to coordinate systems and to monitor the patient's progress. In other cases, there's a year-end penalty or bonus based on whether or not the provider met certain criteria. The criteria may be activity-based. Did the patients have an A1C test? Outcomes-based, did they show an improvement in A1C? Or what were their satisfaction levels based on year-end surveys? Let's turn now to the benefits of value-based reimbursement. So the value extends to patients, providers, payers, suppliers, and society as a whole. Pierre, can you tell us something about the benefits to providers?
To providers, to patients.
Patients.
Let me start with patients first. The benefits to patients is that they will spend less money to achieve better health. But managing a chronic disease can be costly and time-consuming for patients. Value-based healthcare focuses on avoiding chronic disease in the first place. So the result is fewer doctor's visits, medical tests and procedures, and less money spent on prescription medication as both near-term and long-term health improves. You want to say a few words about the providers? About the benefits to providers? Okay. So the providers will spend less time on chronic disease management, but they may need to spend more time on prevention-based patient services. So quality and patient engagement measures improve when the focus is value instead of volume. Also, providers are not placed at the financial risk that comes with capitated payment systems. Even for-profit providers who can generate higher value per episode, even for them, they stand to gain in a value-based care model.
Okay, let me comment on the payers. So like all of the payers, or all the members of the healthcare community, payers are interested in cost, quality, and patient experience, but they're also very focused on risk. Payers set a budget in advance. If healthcare costs exceed that budget, then they might have to scramble to find the money or to adjust their operations. With the major source of risk are large claims, and because value-based is centered on prevention, there's fewer of those. So that is the value to payers. Chitra, what about suppliers?
Yes, John. So suppliers benefit from being able to align their products and services with positive patient outcomes and reduce costs, which is an important selling proposition as national health expenditures on prescription drugs continue to rise. This is not being routinely done today, but many healthcare industry stakeholders are calling for manufacturers to tie the prices of the drugs to their actual value to patients, a process that is likely to become easier with the growth of individualized therapies. So, that's the benefit to suppliers.
Thanks. And let me just summarize now with the benefits to society. Certainly society benefits from the three big things we've been talking about: cost, quality, and patient experience. But I want to focus for this part on cost. In the United States, we spend about 18% of our total GDP on healthcare, compared to 11% in comparable countries. If we can deliver on the promise of value-based care and reduce that percentage, we'll have more money to spend on education and other worthy causes. So now we're going to turn our attention to how this actually happens. Pierre, do you want to kick us off on that?
Yeah, I'll say a few words about the delivery models. The new healthcare delivery models stress a team-oriented approach and sharing of patient data so that care is coordinated and outcomes can be measured easily. And to illustrate this point, we picked a landmark study in psychiatry. And this is the RAISE ETP study or experiment. The acronym stands for Recovery After an Initial Schizophrenia Episode - Early Treatment Program. So it's RAISE ETP. And we chose this example because this is a well-documented attempt to show the benefits of early and coordinated intervention to prevent chronicity in schizophrenia. As you know, I'm sure you know, schizophrenia is a common condition with a lifetime prevalence of about 1%, and it's challenging to treat. It causes extensive functional impairment and low expectation for recovery. Until recently, treatment in the United States had largely attempted to stabilize individuals with chronic schizophrenia. And yet, a number of studies from the US and abroad had suggested that an early and coordinated intervention for psychotic disorders such as schizophrenia could improve outcomes. But those studies were controlled, or they were too small, and the question remained, is the additional cost of a comprehensive first episode psychosis treatment program offset by improved clinical status and reduced inpatient costs? I mean, to make it less words, does the value of health benefits justify the additional costs? And the RAISE study program was designed to address these questions. As you will see or hear later, the results confirm the value of coordinated multi-element specialty care in usual treatment settings. And it confirmed that this approach improves outcomes measured over 2 years. I think the study is going on, and we shall have data about a longer period of surveillance, but right now we can only present those 2 years data. The study also suggests, and we'll come to that in more detail later on, but it also suggests that there is value in reducing the duration of untreated psychosis before the recognized first episode. And then, and it's important, the method used by the RAISE researchers can also be used in other chronic conditions, such as diabetes, to demonstrate the value of coordinated care with a combination of behavioral and pharmacological interventions. So what was the RAISE study? It was a controlled experiment to compare 2 treatment interventions, one called NAVIGATE, abbreviated NAV or NAV, and the other one being the usual community care, abbreviation CC. And 34 community treatment clinics were randomly assigned to NAV or CC, the souped-up treatment or the conventional ordinary treatment. And the 2 treatments were different in several aspects. The NAVIGATE treatment approach was comprehensive, multidisciplinary, and team-based. It also included personalized medication management according to best practice. It included family psychoeducation, and it included individual resilience therapy focused on illness management. And it supported education and employment, many components. In contrast, the usual community care, CC, was provided according to clinician choice and, most of all, service availability. And there were 404 patients who presented for treatment with a first episode of psychosis who were enrolled. I should mention something important here that will come again later on in the presentation, is that the researchers had no control on the duration of untreated psychosis that preceded the first treatment. The duration of untreated psychosis, or DUP, turned out to be a key variable in the study. Its median duration was 74 weeks. You will hear the abbreviation DUP often in this webinar. And later on, you'll see the results broken down by long and short DUP, broken down on the median of 74 weeks. Some of the slides use the adjective high instead of long, and low instead of short, but we are talking about duration here, and I think that long and short as adjectives are easier to use and more meaningful, more representative of what we are talking about. The outcomes were measured at 6 months intervals over 2 years. They were the incremental cost effectiveness ratio, or how much do you pay for a measurable clinical benefit. And this is easy to calculate. And they also looked at how is this measurable clinical benefit, how much is it worth in dollars or some other unit of measurement? And the value of a measurable clinical benefit is a difficult question, much more difficult than figuring out its cost. I should say a few words about the main outcome measure. The main outcome measure was a quality of life scale to rate the schizophrenia deficit syndrome. Deficit symptoms are often the most enduring and crippling aspects of schizophrenia. The deficit syndrome includes emotional dullness, failure of mental activities, and loss of ability for independent action. So to operationalize those deficits, Heinrichs and Carpenter and collaborators designed a 21-item quality of life scale that was rated from a semi-structured interview to collect information on symptoms, functioning, and all that during the preceding 4 weeks. That was the period surveyed. The scale was to be administered by a trained clinician, and it requires about 45 minutes to complete. The maximum score is 126. Now, this is important. The unit of improvement chosen by the RAISE researchers was 1 standard deviation on the scale, which is 88.8 points, 19 points. So I shall now ask Clifton to talk about another facet of the method of the RAISE researchers, the assessment of costs.
Thank you, Pierre. So there were 3 sources of costs. The first is administrative data that comes from Medicaid, a commercial claims database called MarketScan, the Veterans Health Administration, and state mental hospitals. The second source was published reports from the Federal Supply of Schedule of Prices and medication costs. Then the final source of cost is to study administrative records for training and supervision of NAV and the CC sites. Now, the unit of analysis for cost evaluation is the average 6-month health-related cost per patient, calculated as the average monthly cost multiplied by 6. The aggregate value includes health services, medication, and the marginal costs of training the NAV staff. The assumption here is that the monthly cost per patient was fixed for the study duration. Now, the authors used several methods to monetize the estimate of health gains. The least controversial method is some kind of a sensitivity analysis over a range of estimates, let's say from $0 to $40,000 for the dollar value of 1 unit of improvement, right? The 1 standard deviation on the quality of life scale that Pierre had mentioned earlier. because it remains agnostic as to its value. Okay. So the incremental cost effectiveness ratio, or we often call it as ICER, ICER, was calculated as the difference in average annualized total costs divided by the difference in effectiveness, this improvement in the quality of life scale from baseline. The uncertainty of differences in effectiveness and the total cost was estimated using a bootstrap sampling method with replacement. The incremental cost effectiveness ratio for the entire group of patients was approximately 12,000 per unit of improvement. So here, what you're seeing is a graph that helps us to understand what was on the previous slide. So the graph shows the difference between NAV and CC in terms of improvement and cost. Okay, the x-axis represents the difference in QLS scores measured in standard deviation units, the unit of improvement. Okay, the y-axis represents the difference in annualized costs. Now, at the center of the black cloud, you may distinguish a red dot, and if you can't, just imagine it. That's the incremental effectiveness ratio, or ICER. The difference in the QLS change is approximately 0.25 standard deviations. The difference in cost is approximately $3,000. I know they're not listed here on the scale, but you can kind of see that here. The ratio per QLS standard deviation is 3,000 times 4, or 12,000 per unit of improvement. Now, why the black cloud here? The black cloud represents the results of a method called bootstrapping, or sampling with replacement, to estimate the uncertainty around the ratio, its confidence interval. Okay, the 95% confidence range from 400 to 33,000, which is large. But the important thing is that practically all the points are in the upper right quadrant. Okay, you pay more, you get more benefits. Also, this slide represents all patients. The picture is going to look a little different when we get into the short and long DUP patients. And we're going to go to that here next. So now you're looking at the same graph, but this time among the short DUP group. Okay, note that the cloud position is much lower compared to the previous slide. Okay, it's even going below the 0 axis line. The ICER is also lower. See, it's almost hitting on the axis. Approximately 1,000 per unit of improvement. In other words, compared to all patients, in short DUP patients, the difference in cost is less per unit of improvement. Note that the confidence intervals are larger, as expected, with a smaller sample from 12,000 to 15,000. So now we'll see how this looks for long DUP patients. Okay. Now the situation appears to be reversed. The ICER is much higher, the red dot, at 40,000 per unit of improvement. In other words, you have to spend a great deal more for the same health benefit, or the same increase in costs gives you a fraction of the benefit seen in the short DUP patients earlier. This pattern of cost effectiveness is indeed very different for short and for long DUP patients. Oops. Okay. Now, the authors represented the probability that NAV has greater net health benefits than CC at different monetary values of 1 unit improvement from 0 to 50,000. Since there is no universally accepted method to calculate it, okay? So here, we are looking at what's called a cost effectiveness acceptability curve. So the higher monetized value one assigns to a unit of improvement, the higher the probability that the more costly treatment, NAV, will be superior to CC, the standard treatment, okay? This represents all patients, and as expected, this approach gives different results in low DUP and high DUP patients. And like before, we're going to start with low DUP patients. Okay. So you can see here that the probability curve is steeper, right? For short or low DUP patients. In other words, NAV beats the CC even at low values of improvement. Now let's look at long DUP patients. Okay. So the picture is very different. You have to assign high values for unit of improvement for NAV to have a greater than 50% chance of beating CC. See, 0.46 here, or higher actually, between 0.46 and 0.56. So now I'm going to tell you a little bit about an alternative approach that could have been used to analyze these results. The alternative approach to calculate the cost benefit or effectiveness of NAV versus CC could also be done using what's called a Markov model. These models are sometimes considered more accurate for diseases that progress through stages such as many schizoaffective disorders. The main idea is that the benefit of NAV would be examined in a manner it improves the progress or transition of the disease from a lower quality of life to a higher one. Please note that the following slides, including this one, on the Markov model, do not use the race study data, which we did not have access to. They are based on hypothetical data. Okay. So disease progression or transition is often measured from the point of view of a time to a specific event. We can measure the outcome in terms of stages towards recovery and use a survival function and a hazard function. So survival is on the left side, hazards on the right-hand side of this panel, to estimate the proportion of patients in NAV and CC who will experience a transition to a higher stage of quality of life. The left panel gives the proportion who do not make this transition, okay? And for those who are familiar with survival analyses, these are the cohort who survive, all right? The left, in this chart, the red line, okay, could represent NAV or the intervention of interest, and a dotted line, the standard of care, or CC in this case. These charts could be sketched for both long and short DUP as well, right? And on the right-hand panel, this will represent the transition. And if there were a traditional survival analysis, this would not be good because this will represent those who do not survive. Now, here we construct a parametric or non-parametric model that allows us to estimate the percentage of those who will make a meaningful transition, given that they've got NAV or the CC treatment. This model will be used to generate what we call predictive probabilities instead of something like quality adjusted life year. It could still be used to convert to quality adjusted life years, but it's not necessary. Okay. In the clinical world, a lot of times people are much more comfortable with the idea of predictive probabilities. So the red line here shows that the model is using as an example a parametric form called spleen or spline. And the dotted lines are the raw values in the data. Here, the picture demonstrates that this particular model, the spline, fits the raw data very well. And that's important for us to have validity in our predictive probabilities that we are going to calculate. So each panel, right, represents a stage of transition of interest among schizophrenia patients. And in the work that I've done previously, we divided these transitions into as much as 6 or 7 stages. I think the typical average that I've seen is anywhere from 5 to 7. Okay, so this is like the first 3 stage of transition, but you can imagine additional ones going across the screen if we could actually map out the exact nature of transition in a given study. Okay, now the Rosenheck study, right, the RAISE-ETP study, uses a bootstrap method to evaluate incremental cost effectiveness ratios. So for recent implementation of the Markov models, we can also perform a similar simulation using what's called a Markov chain Monte Carlo method. What we do here is we randomly sample a distribution of transition from one level to another of a patient, right, over a given period of time. So in year 1, did the patient make a transition? And if the sampling idea says yes, we put a 1 here. How about year 2? Yes. Year 3, okay, we have 2 transitions, and so on and so forth. Now, this could be months or years. In this example here, remember this is a hypothetical example, I have years and they stretch all the way out to 30, okay? So what we do then is we randomly sample the distribution of transition from one level to another over this period of time. When the chain, right, is completely formed, and notice after year 16, there are no more transitions. That's why you see the zeros here. Okay, we call that in our language abandoning or the abandonment of transition after year 17, or it could be month 17 if we were to use months. After this chain is formed, we will use it to sample 10,000 times in the next stage. So then, after the simulation is complete, the results will yield a conditional probability of transition from one disease stage to another over this period of time. If each stage from 1 to 2 to 3 represents a journey to recovery, here the results indicate, when you multiply all of them together, that about 6.5% of the patients make a full recovery. Okay, so we will yield a composite score at the end. We can compare these conditional probabilities for NAV and CC and across low and high duration of untreated psychosis. Again, these are hypothetical results. This table is not a reanalysis of the Rosenheck data, but what we are looking for is when we generate one for each intervention, the intervention of interest and the standard of care, these series of transitions, if the intervention, right, works better than the standard of care, we would expect the transition numbers to be higher. Okay, and that is what will give us confidence and validity that, yeah, there's some evidence that this intervention works. Okay. Now, ideally, the results from the previous slide will be at the bottom row of this conditional probability table. So we'll generate a table that has these probabilities for each time period. In this case, remember the hypothetical model is in years. Of course, it could also be in months. And we could also generate a separate table for those in the short and long DUP group as well. And so if we wanted to, we can keep the transition probabilities as is if this is more useful for a given disease, for example, an orphan disease or a rare disease. Or we could assign utilities that can be done to stages along with the costs associated with the treatment prescribed at each disease level. Okay. With that information, we can either tabulate the incremental cost effectiveness ratio, as did the RAISE-CTP study, the cost benefit ratio, or even a budget impact scenario, or a scenario showing the cost savings that will be produced as a result of the intervention. These can be calculated from a variety of perspectives, that being of the government or the provider or even of society. So here I will stop and let Pierre step in.
Thanks, Clifton. So now we can try to see which questions the authors of that study did succeed to answer. The results for the NAV group are pretty clear. I mean, there was more improvement on the quality of life scale. There were higher outpatient costs, as one would expect. It's a multi-element treatment approach that has, and each of those elements has a certain cost. And there was higher antipsychotic medication. There were higher antipsychotic medication costs, and the authors attributed that increase to the more frequent use of non-generic medication, like long-acting antipsychotics. If we were to do that study today, would probably not be, the difference would probably go away. The ICER, the incremental cost effectiveness ratio, was approximately $12,000 per unit of improvement. And this regardless of the duration of untreated psychosis, or DUP. And there was a 94% probability of NAV being more cost-effective than CC at an arbitrary value of $40,000 per unit of improvement, regardless of the duration of untreated psychosis. That was the sensitivity analysis graph that Clifton showed you. One surprise of the study was that, these to the authors, was that there was no reduction in inpatient costs with NAV. And this was attributed to the unexpected good care provided in the community centers with the conventional treatment. But the other surprise was that there was considerably greater cost effectiveness among the short DUP patients. In fact, the ICER or ICER was about $1,000 per unit of improvement for the low DUP patients, compared to an ICER of $40,000 per unit of improvement in the long DUP patients. So this was a 40-fold difference. There were some limitations to the study that the authors recognized. Some of those limitations were specific to the study and others were not. They were, general. So the first limitation is that neither the CC type care as delivered in this study or the NAV type care are the norm. Neither of them are the norm in psychiatric healthcare in the US. So the conditions of the study are not generalizable to real world practice in this country today. In fact, the CC sites offer the level of care superior to usual treatment of first episode psychosis in the US. And this may have contributed to, this may have increased the cost effectiveness of the conventional treatment. Those sites, the conventional treatment sites, were exceptionally good at keeping hospitalization low. Now, for those of us who have done clinical trials, clinical drug development with antidepressants in particular, I mean, this type of situation is not surprising. It's often that the control group does better than expected. And this was the case here. Another limitation was that the study was not adequately powered for cost-effectiveness analysis. And you can see that, you can appreciate that by looking at the confidence intervals on the outcomes. The confidence intervals are large. Another limitation was that the duration of the follow-up was not long enough to demonstrate a lasting effect on chronicity, schizophrenia chronicity. So I think that this is the object of studies that are on the way now with that group. Another limitation was that the study was designed from a healthcare system perspective. So we don't know whether NAV increased family burden, for instance. This is the problem of compartmentalization of value in value-based healthcare, because it always ignores some stakeholders. And this is a complex issue, but it could be a takeaway for further discussion or another webinar, perhaps. Another limitation of the study, which is not specific to this study, is that there is no universally accepted method to monetize healthcare benefits. And this also can be a takeaway point for a further discussion. Now, finally, the study raises a question that was not asked at the time when the study was designed. This is the question: can long DUP patients with a long duration of untreated psychosis, can they be treated earlier and benefit from NAV, a better treatment? Can they be treated earlier and benefit from NAV like the short DUP patients? In other words, is a long DUP an external correctable factor, or is it a harbinger of treatment refractory or refractoriness, of treatment refractory schizophrenia? And I cannot answer this question, but I think that we can safely say that, based on this study, that what predated the treatment of the first episode, of the first psychotic episode, was a better predictor of treatment outcome than treatment itself. Now, the promoters of best-in-class care will be tempted to interpret this finding as an invitation to reduce the duration of untreated psychosis, to convert potential long DUP patients into short DUP patients, so that patients can benefit from best in care. But the alternative explanation, this is the pessimistic explanation, is that long DUP patients are intrinsically different and do not respond to best-in-class care as we provide it today. So the overall takeaway point is that, research sometimes answers the questions asked and sometimes raises new questions. And I think this is an example, and I suspect there are many other examples to come.
Thanks, Pierre and Clifton. That was a great presentation. I'll invite Joan to give us some thoughts summarizing, what you've discussed from her perspective. Joan?
Thanks, Deidre. So great presentation, Cliff and Pierre. I really enjoyed it. So value-based care is growing rapidly in the United States. In 2018, only about a third of hospital and doctor spend was value-based. We expect that to be 2/3 in just a few years. We also expect the nature of the reimbursement methods to change with fewer bonus-only type agreements and more penalties. Surprisingly, there's very little in the way of value base for pharmacy, and that's primarily because of regulatory restrictions. I expect that to change, maybe gradually, maybe quickly, just given the intensity of pharmacy costs these days. So if you're thinking about moving to a value-based agreement, how would you start? My suggestion is that you take a team approach. You would start with clinicians like Pierre, who can help you understand the day-to-day practice and how it's going to impact patients. You need a legal team to talk about the risk and making sure that you're following all the regulations. You need analysts like Clifton, who can help you understand the data regarding a specific intervention or methodologies, and actuaries like me who can put all the pieces together. So with that, I'll turn it back to you, Chitra.
Thank you, Joan. That was a very good wrap up. We can take questions now. I know some of you had indicated that you would like to contribute, you would like to actively participate. So maybe we'll get started with a question or two that we have already received and then open it up. So one question that we have received to the entire panel. So this is around the fact that there is a stream of thought that qualies are particularly ill-suited to assess the value of rare disease drugs. Would you like to comment on that, Kristen, Pierre, or Joan?
I don't know. I'm not a specialist of qualities, but I've always felt that it was to a large extent an arbitrary calculation or an arbitrary estimate. This is I think the value of equality is not universally accepted. There are some groups that reject it altogether. The use of qualities has been prohibited in some circumstances. I think Congress has prohibited the use of qualities in Medicare negotiations. But what I found really attractive in this study is that I wouldn't say they skirted the issue, but they recognized that there is some arbitrariness in quality calculations or quality estimates. And the alternative is to do an analysis over a range of values associated with a health benefit. And in this case, the range was from $0 to $50,000 for 1 unit of improvement, 1 standard deviation on the quality of life scale of interest. And it's probably a good method to bring people together. I don't think that we can legislate what equality should be, okay, and assign a value to equality. But I think that there is probably perhaps a method to develop that would consist of bringing together stakeholders and invite them to a discussion on a sensitivity analysis that uses a range of assigned benefits.
Yeah, and with this stakeholder panel, one of the ways that you can also address this issue, if you were to go with qualities, is to also conduct a different sensitivity analysis, discrete level sensitivity analysis with something like a tornado diagram, where if you were to adjust some parameters by discrete values and see what impact that would have on the qualities and the ICERs that are related to it. So that's another method by which you could handle the situation if you thought that the qualities might be somehow, may not be a convincing parameter. Or you can just, as I mentioned earlier, scrape qualities altogether and just go with either some sort of a transition probability metric or some other outcome measure that is based on a measurable survey that is clear and that everyone agrees at the table that this will be a adequate measure of value.
Clifton, are there precedents for the use of the tornado diagram that you described?
Oh yes, we've done that in a variety of studies, both in behavioral health and also in oncology. Oncology uses that quite a bit.
And now, is there a consistent rank order of branches on the tornado diagram? How can I say? I cannot just, I don't know the nomenclature to talk about tornado diagrams, but is the longest bar always the same?
No, it isn't. It would depend on obviously the disease condition and the intervention. The longest bar typically would represent the highest uncertainty of costs per given unit of benefit, and then we would narrow it down from there. So we would rank them according to where the highest level of cost is in terms of this certainty, and then winnow it down to what seems to be pretty narrow, so that when we adjust them by some discrete unit, we can see what the changes might be. And that will differ from diagram to diagram.
I'm just wondering what that diagram, that tornado diagram, would look like for a rare disease or an orphan disease.
Yeah, that's a good one, and I'm sure if we have one to work with, we could talk with stakeholders about how best to take a look at what would be considered conventional, and then apply it to that particular disease. But I find that the tornado diagram seems to be one that engages a lot of conversations among all stakeholders, is one that they can kind of more clearly understand than, let's say, some simulation based on 10,000 bootstrapping that they sometimes accuses economists and statisticians of putting in together a magic wand. But the tornado diagram has that nice feature that it is clear, and it's something that we could get some consensus around from different stakeholders.
Okay.
Yeah, let me just say from a payer perspective, quality adjusted life years doesn't have a lot of meaning. They're much more interested in the expected savings as measured by an analysis like Clifton did than this artificial term quality adjusted life year, where you have to explain both the numerator and the denominator. They are very interested in what the expectations on the patient are. What do we know about lower A1Cs, experience, that type of thing. But the quality adjusted life years doesn't, outside academia, it doesn't have a lot of real use. I will say that sometimes people won't even consider making a change unless there has been some type of proof that may or may not include quality adjusted life years.
Okay, thanks. Yeah. So I would again ask the participants who wanted to speak, if you would like to comment, please send a message. In the meanwhile, there is another question. So Clifton, this is about the I guess your Markov method. So the question, maybe it's for you as well as for Joan, but are there any examples of peer groups accepting or using this probability of transition method?
So I'll start with this one because I come from a payer background.
Yeah.
So yes, this idea is gaining a lot of momentum. It's one of those things that are slow and building. They're usually referred to as decision trees because it's easy if you kind of lay out the path that a patient may follow. And one of the things that I've used it for was looking for opportunities. We did one with orthopedics where we looked at the first time someone had a doctor's visit, how many of them went from stage to stage and where there were opportunities to do something and to intervene. And that was very helpful and resonated with payers.
Okay. Kristen, do you have anything to add, especially in the context of rare disease, the applicability of?
Yes, and I agree with Joan that usually in this case, we do create a series of decision trees where we calculate the probability and the conditional probabilities depending on the branches. And for rare diseases, we would simply include perhaps more branches to indicate areas where there may be, in some cases, more uncertainty. And where if we have the evidence from literature, we would apply that. And if not, if we have access to real world evidence, for example, that would be one way we could calculate those transition or those probabilities of transition and apply it to the decision trees.
Thanks, yeah. So maybe we can have one more question before the end. So given that some policymakers use qualities, how can they be educated?
So here, are we talking about policymakers who are on the side of qualities or oppose?
Yes,
so
yes.
there,
Who are on the side of qualities? So how do we educate them about the
right.
Yeah.
So usually, what we would do is, first of all, even if they are on the side of qualities, there's still some considerable debate and controversy about how the utilities that from which the qualities are calculated, how were they estimated? For diseases like schizophrenia, frequently they're done by physicians, perhaps, and other cases maybe from families, but rarely from patients. And so there's always going to be a pushback that if you're saying that these represents value, but they don't come from the patient's perspective, then what we would need to do is estimate qualities from utilities that come from the patient's point of view. And there's some work that that I know of in Europe, for example, that are now looking into how to estimate these utilities from a patient perspective. It's very difficult, and it's also being done in other disease areas too, such as oncology, for example. And so we would have to then ensure that we understand what perspective was used to calculate the utilities that inform their qualities. The other thing we could simply do is just tell them, well, maybe the quality will be one approach, and we may have to supplement it with something like a budget impact model or some other approach that we can see if to which extent they agree or disagree, and not put all their weight in that one basket. That since qualities is not really widely accepted everywhere, and there's still some discussion about how to really interpret even the value of a quality adjusted life year.
Okay, thanks, Kristen. I guess we are like at the end of the hour. So thanks very much to the panel. Thanks, Joan, Kristen, Pierre. I hope the participants found it interesting. Thanks again, all of you, for joining, and we hope to see you again at our next webinar. We'll let you know when that happens. Thank you.